Welcome back, everyone, to the next episode of MedEd Matters, your medical education podcast. I'm Omar Young. I'm a maternal fetal medicine specialist at UNC, and I'm accompanied by my buddy, Abhi Shripad. How you doing, Abhi?
I'm doing well, just getting through clinic, but no better time to chat about the latest and greatest in medical education.
Great. I'm coming to you this week from the Society for Maternal Fetal Medicine in Las Vegas, and then next week is we have our meeting for the what is it called? Creog and APCO meetings. Can't remember
Yeah.
anything. So it's going to be a medical education fest for me the next 2 weeks, but we have a very special episode for our listeners and our viewers today. Lauren Siff has agreed to chat with us today about technology and innovation in surgical training, and so I'll let Lauren introduce herself.
Yes, thank you guys so much for inviting me. I can't wait to learn from y'all and contribute to the conversation. I am Lauren Siff. I'm a urogynecologist. I'm chief of GYN surgery and urogynecology in Richmond at the Central Virginia VA. I have a variety of trainings, which we'll talk about, I'm sure, later. So I'm an associate professor in OBGYN urology and surgery. And then something I'm excited to share with you guys is that I'm founder and inventor of a surgical ed VR, which is a surgical training platform. And I know we'll get into that when we talk about technology and SIM.
Awesome, awesome. Well, surgical simulation is a really hot topic these days, and especially with declining numbers in of open surgeries as well as more complexity of patients that we take care of. So I think will be an important episode for anyone that practices complex gynecology or anyone that is teaching it. So I'm happy to have this conversation.
I'm very excited. And so, Dr. Siff, just, even hearing your multiple roles, I think it's helpful to even take a step back and hear your journey through this process because obviously you're doing a lot of different things in our field. Um, Tell us a little bit about sort of how you got to this point.
Yes, I like all the way back. I really think I was actually born into education. I'll just say it that way. My mom is a French teacher or what, a former French teacher. She literally has endless energy, you guys, and such a passion for teaching and taking students on trips I can't even imagine with my own children, taking like multiple students on broad. But honestly, she had the reputation as being like the toughest teacher, but was always known as like the most engaging, fair. Their kids were successful, and like people would come to our house and call our house all the time. And that after they graduated, and to me, that was really impressive and left a an impression to me. So. I think after that, like I continued wanting to teach and always teaching those, that came behind me. So, as a resident, you teach the students, as a fellow, you teach the residents, and so on. Yeah, I actually pursued a distinguished educator certificate when I was at the Cleveland Clinic, and so to learn more about the learners and the process and in education in general and principles. And so after that, I ultimately, as faculty, started taking on a wide variety of learners. So I was core faculty for our GI, pelvic floor GI, for colorectal fellows, both in the operating room and in the clinic. I did a rotation for internal medicine residents interested in gender-specific care at times. And then I also did some precepting for wound ostomy and continence nurses. And so I think with that, you start to get a lot of feedback and learn a lot about different types of people, and that kind of fuels you to keep going. Um, but when we think about really how I'm teaching the way I'm teaching now, and working on surgical training, I always had this conversation starting. I can remember like my first year fellowship talking to Mark Walters in the operating room, a mentor of mine, like how do you train the hands of surgeons? Like how do you control them, train them? How do you teach someone's hands? And specifically to me, how you teach someone to operate by feel or blindly, when you can't see what they're doing, you can't feel what they're feeling, and that's huge in vaginal surgery, as you guys know. And so, I started thinking about gaining perspective. And so one day I remember literally, I was in Cleveland first year. I called up Mark and I said, this has got to have already been done. I'm sure it's so obvious to everyone else, but would you be willing to come and film a case with me operating from below? So, doing a vaginal surgery on a cadaver with an open abdomen. And that way we can kind of see from above and below. He's like, that is brilliant. How have none of us ever thought of that? And I was like, well, probably somebody has, but I don't know. I've not seen it. Are you willing? And I started there. Um, and realize that like sometimes the simplest ideas are probably like the most elegant, impactful. And so really it was through that experience, editing that video even. I met with a video editor at the time, just listening to him, getting to know him, telling him what my goals were. And he connected me. He said, have you guys seen this? Have you seen this TED Talk? It was a TED Talk of the Case Western faculty member in Cleveland Clinic that was at the time changing their anatomy lab to holographic learning. He sent me like a link right then, texted me a link to this TED Talk. I watched it, immediately sent a cold email to the Dean of Technology in Cleveland and was like, I need to do this. Help, like, can we partner? Thinking like he'd probably never write me back. And we did. And I started working then with augmented reality, gaining perspective for vaginal surgery, and it kind of has evolved from there.
Awesome. That's like really impressive. And so when you say augmented reality for our viewers, tell our viewers what that means and describe what you have created.
There are a variety of kind of this extended reality. So you might hear the term XR, which is just for the kind of the bucket term. Augmented reality is something where you're really still in your own reality and augmenting it with some other views. Sometimes it's also known as mixed reality, and I think those lines are a little bit blurred. But something like HoloLens or even some of Microsoft's or Apple's newest products too, where you're still in your own, you're still working in the real world, but you can have mixed media in front of you. You can see holograms, you see other things. You're still kind of not fully immersed in, if you will, versus virtual reality, which is where I am, where it's like if you put it on and you turned off the media, it'd just be black. Like you're completely immersed, both sound and visual. And then there's a kind of a spectrum, and you'll hear people talk a lot about each one of those things. For me, I'm working currently on a platform using virtual reality where from a kind of a setup or hardware perspective, you've got a virtual reality headset, you've got a laptop, and we've got a haptic hand held device that the end of it, which is kind of looks like a stylus, the end of it we've altered to look like your surgical instrument. So the goal being you put the headset on, you're taken into the virtual operating room, and in front of you is your patient. And your patient, in our case, is real patient anatomy. It's taken from CT scans. We have broken that down to make it as unblinded or simple at level one, where it's basically, and I should say, the first procedure on the platform is a retropubic sling procedure, or a sling for urine leakage.
Classic for your gynecologist.
Woot woot.
Yes. But truly a procedure that's, common, effective, and done by feel, right? So level one, you can see everything. It's so simple. It's like a pelvis, a bladder, and some blood vessels, and that's it. And then levels and a pathway to follow. An expert trajectory where you will like learn that muscle memory by continuing to follow the path. And then we add on levels of complexity, removing your guidance, adding in layers of anatomy, and increasing the complexity until you're at the final level where you're at real world conditions. Your full patient with skin and tissue is in front of you, and it's basically blinded.
So, what would you say is the goal of the simulator compared to, let's say, I'm a GYN resident and I'm learning to do a TBT, TOT. What would be the advantage of using something like this as a learner?
So one, the I really want to focus in this case on one or like key task, and it's usually the task that as a learner you're probably least likely to be performing, especially early on. And it's passage of the trocar. So you've got an entry and an exit point. The rest is done by feel, and your faculty member or mentor is watching you like with totally clenched and like afraid that you're going to have a complication and that just really waiting with bated breath. And so I really wanted to get you that feel in your hand because you otherwise will not feel that sensation in any other task that you're doing. While there's some transferable skills, this is a unique one. And you really need to just get the feel over and over and over again to really understand when we say, hug the bone, ride the bone, touch the bone. Like, what does that actually mean? And so the goal is one, that you get the feel of it, and two, that you have a benchmark to follow. And then in our case, it's not just training, it's the assessment that you get a score. And that score is benchmarked by an expert because it's really rare as trainees that you're getting specific feedback and know where you stand with regards to kind of a goal or benchmark performance. And so our goal is when you get the feel, you get the pattern, pattern recognition, and you get some real-time feedback.
No, that's
That's
great.
great.
I think, one of the things that we're moving towards in medical education is competency-based medical education. And
Can't not tell this story because it was at UNC too. We were there for the fellows lab, and I was watching a resident, a fourth year resident going into Uruguayan. Thank you guys for training the future. Who was working on the simulator, getting like 30%, 40%, kind of typical for a resident. And I said, "Do you feel that?" And at first it was kind of like, when you're in the operating room and you get the head nods, like, yeah, 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 uh-huh, I feel that. No idea, right? And then you actually see her feel what you're wanting her to feel. And then like every other level after that was like 60%, 70%, like continuing to improve. So like watching that in real time makes me want to keep doing this.
Yeah. And, being able to, see the comfort of the learner with that objective thing that they can follow up with, I think is really powerful. To even take a step back a little bit and talk about simulation in general, obviously you're in this world with, a very, very advanced product. And I can't imagine all the people that went into designing it and testing it and all of that. Do you mind just kind of walking us through just some very base level things to be thinking about for just principles of simulation and medical training, sort of things to keep in mind, learners, what levels to be considering with each level of learner? I know that's a big question, but just to kind of approach it from a broader perspective.
Yeah, definitely. I think a couple things come to mind. One for design of a training, as I think about how that should be designed, I really want to say, like, we never focus on the discovery part. And I actually, in coming up with this, came up with participated in a formal program through the state of Virginia and did discovery with 36 like key stakeholders that have a diverse opinions, like simulate heads of simulation centers, chairs of department, trainees of all different levels. Because we think, oh, this is how I do it. We know everything. Like I just am here to impart how I do it to you, which is totally not true. And so discovery number one, super important. And just to listen, right? In this discovery, I'm not telling you what I'm doing. I'm asking you what we should do. So that's number one. And then the whole idea of validation in simulation is really interesting one. Some of it just means like, uh, are we learning what we think we're learning? And in my opinion, some of that has I think you have to start with adoption. Like, I could have the best simulator or best simulation on the planet, and if nobody wants to adopt it, it's really worthless, regardless of low tech, high tech cost. And so we spent a lot of time getting feedback about that. Like, and we heard 100% of people, right? Trainees, experts said, if this were available to me, I would adopt. This 93% of experts said, what I learned from this, the metrics that you give really would truly help me evaluate a trainee. So that's like discovery and validation of the adoption are huge. And then some of the other things that we don't think about, like human factors, really like how usable is this? How feasible is this in your daily workflow? And so did some studies on that. Looked at skill differentiation. Can I actually differentiate an expert from a trainee? That's key in simulation. Does your simulator actually can it actually tell? And we started developing metrics, and you then look at your data, develop metrics, and look for patterns. And in our data, we showed like experts all kind of operated like each other, and they were deliberate. They had smooth motion. They were had very like great use of haptic force. It was always really smooth in comparison to trainees who were really like in a discovery mode. They operated, and in this case, it was truly novices, operated differently from each other, different from experts. And then we went from there, developing benchmarks, developing an assessment. And you don't have to, if you're developing simulation, it doesn't have to be that high tech. You don't have to develop an expert benchmark and a competency scoring. I mean, we want to, and this is our love, but you have to have what are you going to evaluate? Can you do that? And how are you assessing it? And how are you giving that feedback back to the learner? And do they actually hear it and receive it? So I think that's some of the principles and some of the key things that we thought about in developing this simulation
I'm
Yeah,
really,
that's that.
oh, sorry, go ahead.
No, I'm just it's just such a thorough kind of look at sort of what you said in the discovery phase of different stakeholders. I'm curious to hear, like, you probably had a vision for maybe how this would look when you started it. How different after the input of all the stakeholders in that process did it end up looking compared to where you started?
I mean, um, such a good question. I tried to do a lot of the discovery up front to design based on that. But that took us in a different direction. Like, definitely, we already knew we wanted objective skill assessment. We already knew we wanted this to be by feel. We knew we wanted it to align with privileging and credentialing because, but I didn't really think how important it was to not, and you talked a little bit about levels of trainees or levels of learners who we should address. I thought less at the time about the importance of training the faculty or practicing physicians. I think that part is extremely key. We are often not um, pushing ourselves to better ourselves or to continue learning, and again, assume we know everything. And so and even if as it comes down to privileging credentialing certification, it's wild that in like this day and age, the tens of thousands of surgeons that get in all specialties that get board certified every year with zero assessment of your hands-on skills. That is definitely changing. You know, a spoiler alert, I did just get back from an ABOG simulation summit. So I think like we're in great hands. Our specialty's way ahead. But I think what we heard in our discovery was that case logs, visual simulation, proctorship, none of this gives you like credible, defensible data metrics that can show that you're a competent surgeon. And so we really started to focus on that piece.
No, I'm glad that you mentioned that. I think, being able to demonstrate the skills that you purport to have is actually really important to have appropriate patient and outcomes. I'm also happy that you mentioned that you don't necessarily need to have like a high fidelity or simulation, just because, there are many clinical scenarios. I come from the MFM world. We don't necessarily need to have like high tech things in order to teach like critical skills. And so um, it's really good to know that if you want to get involved in simulation, you can create it, but you don't necessarily need to have like gobs and gobs of money to do that. But it's nice to have all the bells and whistles to accomplish your goal.
Sure. I mean, I think the bells and whistles and the funding and all of those things help you widely disseminate and when you're ready to do that. And even kind of on the commercial side of things. Um, but that being said, a successful simulation definitely doesn't need that. It needs a goal. It needs your learner to come in with a goal to learn. You ask maybe who's best for simulation. Um, it's any level. It doesn't need to be a medical student, a resident fellow. It's any level who has a goal that they want to improve and that you have a task that you can teach someone to improve upon. That could be communication. That doesn't have to be physical skill, but certainly all of those things can. Actually worked with a medical student on a systematic review a couple of years ago, looking at everything available in simulation in urogynecology. And there were tons and tons, all showing improvement. Models, cadaver labs, workshops, low fidelity, high fidelity, virtual reality, all of the things, they all showed improvement, but only sadly like 5% or less of those became widely disseminated, became commercially available. So it was a lot of individual local programs doing great things. But I think something like your podcast and like, our world now where we're connecting folks who are doing this work is really amazing because making that process of the dissemination easier is will be a big difference maker for us.
And switching gears a little bit to sort of, for our listeners who either are program directors or just, faculty with trainees, taking from our conversation maybe a few kind of nuggets for themselves, like saying their next OR day or anticipating that or clinic day or, whatever it is. What would you, if you had like a piece of advice or two for somebody who doesn't have a big curriculum, doesn't have a high fidelity simulation product. What are things you've sort of mentioned, the measurable, kind of metrics and that sort of thing? Anything beyond that that you feel like would be very helpful for people to kind of like think about who are interested in incorporating simulation into their teaching?
I think starting with what is the problem that you want to solve? What is the challenge in focusing on discrete tasks rather than I want you guys to get better at vaginal hysterectomy. Like picking the discrete task, let's say anterior entry, picking something that we know is challenging and is challenging for folks, and maybe they aren't getting the reps, or there's something that you feel like they could do to improve those skills. And then documenting that, like putting it on paper, I think is one of the hardest things that we do, but like put on paper. Number one, this is the problem I want to teach. Number two, these are the key things that need to be done. Some of it you can find, right? Like there are cognitive task analyses published in our literature about many, many procedures. You can find what are those key tasks and what does everybody else think are the key tasks. And then hone in on that and in whichever manner you want to simulate it, even if it's a discussion ahead of time, even if it's a hand motion ahead of time, but really, setting your trainee up with the goal, with the materials that they can prepare ahead of time, prior to simulation, even those who come prepared with their goal that they need to know, always do better. Always do better. Things that are really great to teach are something that needs like visual or a visual repetition. If I talk about the anterior entry, it took me a while, even as a fellow, to see like this is the bladder, this is the peritoneum. If I saw that 10 times in a row on video, or you just pointed it to me on video over and over and over again, I will now understand what you're talking about in the operating room. So giving them something to prepare ahead of time and then just honestly put it out there before you feel ready. Like that's the hardest part, right? Like put your stuff out there before you feel ready and ask for feedback. It can be embarrassing. Like your intern might actually know more than you about whatever the form function of your training is. Just put it out there. And
Breaking
be
news for anyone listening. Breaking news.
you're right. Put it out there before you're ready. And then like don't be defensive about it, whether about your simulation or about your teaching in the operating room or about your operative skills. Like those are ways that we generate that culture of people wanting to improve.
So I think for simulations, this is like a great encapsulation of something that we as educators talk about all the time, or creating a SMART goal. So something that's, specific or measurable and achievable and relevant and in a finite period of time. And so I think that will help, anyone who's doing surgical sims as well as program directors in navigating what their curriculum is going to be. So in that vein, what do program directors, like either residency or fellowship directors, need to think about when they want to integrate simulation into their curricula?
Oh, it's a good question. I mean, I think, you know, gone are the days of practicing on patients. Like, open your mind to simulation, is the first thing. And I would say, like you show by example. Where your values and your goals are. If you want, and your goal is you want your people to be at the top of their game when they show up to the operating room. You want your patients to get the best outcomes and just really impressing upon them that the way you do that is simulation. The word simulation sometimes gets like a bad rap. Training, pre-OR training, pre-workout, whatever you want to call it to make it, appealing, I think, but really impressing upon people that just like athletes, just like exercise, just like any pilots, just like every other high risk specialty or career, we need to come prepared. And so starting that. And then you can crowdsource what's happening at your own institution. There are probably many people who could either help you create simulation or you already have it, you just don't know it. Or honestly, ask your learners. They probably know what they would like to do. Task some of them to help build it together, knowing that you set here's our long-term goal. And I think that will be like the foundation for your curriculum. But then picking those tasks that are common or super rare that really need to be learned by repetition.
Awesome. Awesome. So, I think our listeners will have benefited from this conversation and basically how to get a simulation program off the ground, why simulation is important. And, I think we as educators really need to start integrating technologies into our curriculum. We are so holding hard and fast into the old adage, like, because this is the way that I was trained, I have to train future generations like this. So I appreciate having conversations like this because we need to be innovative in our curriculum. So in that respect, we usually always end every episode with a med-ed moment, which is something that you, as our guest today, would really want the listener or viewer to take away from this conversation. So what would you say is your med-ed moment?
Perfect. Okay. Oh, goodness. I guess I'll frame it with I totally agree with you, and that those same people, if you listen in the back of a conference, those same people who are saying, like, it's not like it used to be, trainees aren't trained like they are the same ones not doing the training, are hesitant to allow their trainees to learn either outside or inside the operating room. So I'm so glad to be on here. Med-ed moment for me, especially with technology, simulation isn't a game. Like, don't think about these as a game. Virtual reality, it's not a game. It's not a video game. It's not a game. When people say, like, oh, let's go play with that device or play, it's not a game. Approach it as skill building. This should be skill building. It should be career development. This is something where, and we put so little time and effort into our own skill building and career development. It's amazing. For our learners, observing someone else operate in the operating room, and watching how they communicate and how they function, you will learn infinitely. It's not always hands-on too. So kind of be open to optimizing yourself so you're ready in the moment, and then just taking that moment and for all that it's worth.
I love that. I love that. Dr. Shripad, do you have a med ed moment?
Yeah, absolutely. I'll just piggyback off that last comment and then I'll give you my meta ed moment. I just think that that idea of like you never really know where, you're going to get that skill to click or knowledge or anatomy. And, I think for faculty, learners, it's just you never know when you're going to see things that click and, to be open to that. And I think looking at simulation as, not something to just do when at the end of an OR day and you have like 10 minutes extra, but rather like a very intentional use of that time, even if it's a short amount of time to do it. My med ed moment, I really liked your point about, you know, using the stakeholders to sort of develop the simulation, even if it's something very low fidelity in the office or something very simple. Sort of the domain experts, quote unquote, as, surgeons maybe set the metrics or set the, evaluation, but I really like that being driven by, folks who are in the learning position to kind of identify what exactly are the specific points that they need help with or are having trouble understanding or skills that they need development. So it's sort of a bi-directional process.
Totally.
I love that. For me, I guess I would say learning is multimodal, right? It's not just doesn't happen with direct patient care. It can happen with, stimulation. It can happen by observation. And I think that's really important for our learners to take away from this conversation is that you are going to be learning in many different types of ways with the ultimate goal of making you into a competent surgeon.
Right.
And so I think that is going to be beneficial not just for our learners, but also for our faculty who need to retain their skills. And, we always say medicine is a lifelong learning process where we don't ever stop being students. And so I think we as faculty, as we keep that in mind, that will only make us better educators. So I would love to thank Dr. Siff for coming on today's episode. I had a great conversation. And to all of our viewers, thank you for watching. To all our listeners, thank you for listening. And we will be back next time to talk more about surgical technologies in a future episode of MedEd Matters. Have a wonderful day.
Thanks, guys.
Thanks.